Dr. Jorge Gonzalez. I'm a cardiac electrophysiologist from Guadalajara, Mexico. I'm going to talk about primary prevention of sudden cardiac death in heart failure. Is it time for improvement? To do so, we're going to identify the population that we wanted to treat. If we divided the population in three by risk, then we have the lower risk in the general population. For those patients, we use public access defibrillator. Then we have the higher population or the higher risk population, cardiac arrest survivor, we use secondary prevention, that is the kind of patient that should have an ICD. Then we have the moderate risk, defined as a left ventricle ejection fraction less than 35%, 30%, denominated as a primary prevention. But we have other two groups or other groups that are not really included in the guidelines or in our recommendation. One of those are primary patients with prior coronary events with a higher LVEF that recommended in the guidelines. And other groups are patients with arrhythmia risk markers. And this is not new data. We have around 10 years of clinical trial tested different variables associated with sudden cardiac death and the use of ICD, clinical, genetic, electrophysiological markers, automatic or anatomical characteristic. But at the end, we place an overwhelming emphasis on the use of ejection fraction. And it came from basically two trials. One of them is MADID-2, published in 2002. And the second one is SCOT-HEP, published in 2005, both in the American and the New England Journal of Medicine. And those trials are the one responsible for the recommendation that we use in the guidelines. As you will know, in the more recent guidelines, there are two groups, one with ischemic heart disease and non-ischemic cardiomyopathy. They're basically the same recommendation, patients with symptomatic heart failure, plus an LVEF less than 30%, with a expectancy of survivance more than 1 year, already on optimal medical treatment. The issue with these guidelines is that we're using the same recommendation as 15 years ago. So what does that mean? Let's see, are we really paying attention to the guidelines, or we're applying the guideline? This table came from a sub-study from the Paradigm heart failure trial that divided the population studied in 5 different regions. I want to ask you to pay attention to the North American, Western Europe, and compare with Latin American, Asia Pacific. The first in blue are the characteristics from the population. Even though there's a statistical significance, in practical are pretty much the same population, around 60 years old, with pretty much the same LVEF, around 30%, with the same functional class measured by the New York Heart Association class. So what about medical treatment? If we pay attention to Latin America, we can see that we're using as a region more than 90% of the patient beta blockers, similar to what they use in North America or Western Europe. And even in the use of mineralocorticoid receptor antagonists, we have a better adherence. That means that we, in the Latin American, we understand guidelines in the medical aspect. But what happens when we add cardiac electronic devices? Then we have a huge difference. The ratio of implantation in Latin America is 4%, to in Asia Pacific, and compared with North America, that is more than 50%, or Western Europe, that is more than 30%. Maybe you can argue that this more than 50% is way too much, and I could agree with that. But still, 4% of implantation rate is too low. The first conclusion probably that comes to our mind is economic aspect. So let's zoom in on this economic aspect. These data come from the prospective Asian heart failure registry. They divided this registry in 11 countries and 3 different income regions, high income, medium, and low. Let's see what factors are associated with the ICD utilization. And it's obvious, as the higher the educational level of the patient, more probability of having an ICD, and the bigger or the higher the income of the region, more probably they will have an ICD. So that makes sense. What we thought before, that economics is all about ICD implantation, but let's see a different coin of this data. So what is the patient perception toward device therapy for heart failure? This table shows the main reason a patient are not willing or uncertain about receiving device therapy, and surprisingly, less than 30% is about the cost. But the thing here is that 55% of the patients were either unaware of the benefit of or needed more information on device therapy. This is not all about economics. That is a fail for us, that we're not giving the right information or the right tools to the patient and to our colleagues to show the benefits of having this kind of device in therapy. So moving on, so it's really the guidelines are representing the population that we're treating. I'm going to focus in two subpopulation, one by the age and one by the gender, meaning female sex. And if we see the two trials that give the guidelines, the MATI2 and Scott-Heff, we can see that the mean age is around 60, 65 years old, and the percentage of women included in the trials is 20%. So is this really the population that we're treating? And this comes from a population-based analysis of near 100,000 patients, and we can see that the population being treated with primary prevention is way too older, is around 75 years old, and obviously the population is half of them are women. So what about the influence of age on primary prevention? It came from a prospective registry in Ontario, Canada, with near 4,000 patients in primary prevention, where 40% are patients older than 70%. So let's see if the ICD is doing the job in this population, and we can see that appropriate shock is just the same. It doesn't matter the population that we are referring to. If you're younger or older, the device is going to do the job. But is this appropriate shock influencing mortality? The answer is not, because population older than 70 years old have less survival as a younger population. In this subgroup analysis from the Danish trial, they made the optimal age cutoff of ICD implantation at less than 70 years old. And this came from the idea of the mode of death. What did it mean? I mean, in the younger population, or younger than 70 years old, the ratio between non-sudden death and sudden death are really equal, 1-to-1, but in the older population, this ratio is 3 times bigger in the non-sudden cardiac death. That is the reason when we compare population older than 70 years old with or without an ICD, there's no difference in mortality, because mortality and the benefit is influenced by the relative risk of dying of non-sudden death. So what about being a woman? This is a table from the bigger 5 trials on primary prevention. We can see again that the percentage of women included on the trials in the best of the scenarios are 28, and it goes to 9%. So there's an obvious underrepresentation from women on the trials, and the issue here is that this underrepresentation gives a false data about the utility of doing it. In this table of hazard ratio table, we can see that it doesn't show a benefit from ICD or non-ICD. That has not sense. But the problem is here that this misleading information made the woman 40% less likely than men to receive an ICD therapy, and it came from the American Heart Association with the guidelines heart failure quality improvement program. So this is a problem. So what I think, so increase in adherence to primary prevention depends not only on the patient medical condition, but also on the geographical and socioeconomic environment, meaning that if we want to improve, we first need to generate specific data on our population, not only considering our health system or incomes, but also on education. By last, I want to show you what for me is a first good step to optimization that is called the improved SCS trial, and this is extremely interesting for us because it came from emerging countries, including countries in Latin America. The main objective was to define a new population of risk, defined as a primary prevention 1.5, those patients with syncope, non-sustained VT, PVC more than 10 per hour, or a lower ejection fraction of less than 25%. And the idea was to see the difference between primary prevention, secondary prevention, and this 1.5 prevention. It is noted that this population has a bigger risk or higher risk than primary prevention, not as high as secondary prevention, but this call our mind that is the right way to optimize our resources. I'm not really sure if it's the right way to do it, but it is for sure that is the kind of data that we need to take our own decision as a region. Well, I appreciate your time, and I hope you found this information useful. Thank you.